what I want to try to do is to try to bring to you some understanding about why we have such difficulties with patients with functional GI disorders. We're going to take it from a historical and philosophical standpoint and then tell you what we might want to do about it. This is a note that a patient put on my desk after seeing a patient of mine last year. Now, that maybe begins this story. Admittedly, the patients that I see have severe, difficult to understand and manage patients with functional GI disorders. And like patients with other somatic syndromes, like fibromyalgia, chronic fatigue, if you think about it, these patients were not properly trained to deal with. In fact, our educational system really doesn't teach us how to manage these patients. I think that the way we can look at this, and my proposal, which is that there's a problem with separation of mind and body. About 4 or 5 years ago, I made this statement at the IFFGD, the International Functional GI Meetings. And what I was saying is that the concept of separation of mind and body is so dominant in our healthcare system that it has profound negative effects on research, patient care, and even the patient-physician relationship. It wasn't always that way. Now, if you think about it, in Eastern cultures that doesn't exist, and even in Western cultures a long time ago it didn't exist. It was first Plato over 2,000 years ago who brought forth the concept of holism. That is, that the mind and body were together, and that the physician has to deal with the whole person when dealing with patients rather than the disease part. Now, things changed around the 17th century. And at that time, Descartes came across with the idea of dualism. And the question is, why did that happen then? I'm sure some of you know Malcolm Gladwell in his books. He talks about the fact that for major changes in society to occur, society has to somehow be ready for it. And if you think about people like Steve Jobs and Bill Gates, they may not have had the success that they had if they didn't do their work at the time where computers were starting to go into the home. In other words, it became an exponential effect. It was an exponential effect for them to do their work with home computers starting. So what was happening in the 17th century? Well, at that time, there were socio-political movements about separation of church and state. There were political elements that were leading to this idea that the church and state was separate. And that may have harmonized with changes that went on in medicine. Up until the 17th century, the human body couldn't be dissected. And the reason was because the spirit was thought to be in the body. Here comes René Descartes in his Letters of Philosophy in 1637. He said that the mind, res cogitans, is separate and distinct from the machine-like body. That idea took hold possibly because of the socio-political ideas, whereas it might not have at another time. And what that allowed for was the dissection of the human body. And with that came pathology, the science of pathology, and then histopathology, and later radiologic imaging, and then neuroimaging. And if you think about it, most of our diagnostic studies are morphologic. So the folklore of dualism has brought us to the idea that when we see something, that if it's morphologic, we can define it, diagnose it, and feel comfortable that we know what's going on. The counter to that is that any condition at the time that was symptoms without morphology or behaviors or mental illness was considered at the time possession, which gave it a stigma, and then later insanity. And so these patients with mental and behavioral illnesses or symptoms were relegated to the asylums. And in fact, it wasn't until the beginning of the 20th century that Benjamin Rush allowed the study of mental illness to go into the medical schools. So there has been this negative attribution about behaviors or symptoms without pathology. And so we're really left with this hierarchical system where at the top we have disease, which is verifiable based on morphology, and we now call that organic, and illness, which is the perception of ill health, and we call that functional. And so this is permeated to the present day, this distinction. And if you think about it, doctors and patients and regulatory agencies are all dealing with this phenomenon. If you want to carry this into the medical model, this is what we call the biomedical model. And the features of the biomedical model is a linear association between biological predisposition to disease. And you can give an example for biologic predisposition of, say, the NOD2 gene for Crohn's disease. With the proper environmental exposure, say a gastroenteritis, you get the disease, and the disease has a direct association with the illness, and then that leads to the clinical outcome. There could be a psychologic overlay, but what I want to focus on is this linear directionality. And does that really work with human illness? This is the point of why the biopsychosocial model may be more relevant, because there are a couple of things to think about. The heterogeneity of disease that we know now, diabetes, Crohn's disease, HIV, cancer, can't be explained by a single biologic predisposition. These are multifactorial etiologic conditions, and their clinical expression is varied. And the second point is, does illness really relate to disease? And I want to focus on that a bit. How do you explain someone who has no GI symptoms and then presents to the emergency room with a GI bleed, painless, or a bowel obstruction, and then another patient with typical ulcer disease repeatedly goes to the doctor and they find nothing, or they might have mild inflammation or nothing at all? So how do you explain illness without disease? Let's look at this in terms of real life. This was a key study by Kurt Kroenke in about 20 years ago. And what he did is he looked in the ambulatory setting at the patients who came to the doctor in primary care. And what you see on the bottom are, over this one-year period, the top 10 conditions that were seen. And then he followed these patients for 3 years. And what you see in blue are when, in that 3-year period, they came up with a diagnosable disease. And what I think you can see here is that that was not likely, that they came up with something. And this is a dilemma, because we're trained to treat disease, but we're in reality working with illness. And that's what a lot of this symposium is going to be like, is how do we deal with those conditions where we don't see anything? Interestingly, this is so prevalent in the way we think about things, we don't think about it very much, we just act on it, but the media picks up on it. How important it is to have a diagnosis. So to give you an example, chronic pain is a condition where you can't see or measure it. Okay? Elaine Scarry, who wrote The Body in Pain, said to have pain is to have reality. To hear about pain is to have doubt. So it's a very different kind of construct. And if we become subspecialists, we can hide behind the idea that we could do our job and not necessarily have to diagnose. We can do our job by doing an endoscopy. So here you're seeing the gastroenterologist who's quite happy about finding nothing, but he did his job, and the patient is still left with a condition. So we're seeing this kind of a gap. One of my GI fellows who went into practice, this was several years ago, she said that going into practice, she was told that seeing the patient in the clinic is a segue to doing a procedure. And there's no end to how many studies you can do. The reason why there's no end to the studies you can do is because society reimburses you for the tests, not for the diagnosis. William Osler said 90% of the diagnosis is the history and physical, but in real life, we're learning that we have to really do procedures or see the patients faster. Now, this cartoon, of course, is showing that you can keep working them up. But the other point that is very critical about the dualistic system is the second point, that if you don't find anything, you automatically assume it must be psychiatric. This is a very common observation among clinicians. And here's a great cartoon from the New Yorker. I'm sure you've seen this, where the internist, and if we talked about nonverbal behavior, the internist, without a doubt, is very happy to turn over the patient to the psychiatrist, who waits. And if you look at the patient, look at her eyes and mouth, and if you're aficionado of nonverbals, you're seeing both surprise and non-acceptance. And she has a right to feel that way because at no point was a psychiatric diagnosis made. But our behavior is to give them that attribution. And there's more, because not only do we give them the attribution, but it affects our behaviors. This is a grid that's showing the relationship of disease to illness, and we plotted some conditions on it. And so the bottom left is the absence of disease and illness. We call that health. And the top right is illness and disease together, and we call that rightful suffering. And conditions like AIDS, cancer, COPD, we clearly understand their suffering because they have something to show for it. But what about when you have a functional condition without the morphology, as shown in the bottom right? Those are the conditions that we may react differently to. And here's a study that we did a few years ago where we looked at patients, we looked at our GI fellows, and we had them fill out a form of these questions on patients that called them at night or on the weekends during, so the stress was, this was night call. Patients would call with nausea, vomiting, diarrhea, and they would rate the seriousness of the problem, their disability. And these were the same symptoms between the functional and organic. Rarely was it a acute emergency. Most of the time it was symptoms like pain, diarrhea, vomiting. And what you can see is their attribution was to take the organic patients in it more seriously than those with the functional in terms of how serious the problem was. And some of our data has shown that the patients with functional conditions actually have poor health status in terms of psychologic scores, pain scores, utilization, days in bed, telephone calls, and the like. So there are cartoons that talk about how we stigmatize the patient. This may be a way of looking at how frustrated we get when we start to blame the patient, get them out of the bed. And psychiatry's no better. This is single session therapy under managed care. Well, what's the problem here? What can we do about it? Now, I think Paul Valéry, who was a poet from the early 19th century, was talking about art when he wrote this poem, his point, that to see is to forget the name of the thing one sees. What's he talking about? Well, I think he was talking about in order to understand the essence of something, you need to not be biased by prior values. In other words, isn't that what we're doing when someone is labeled as functional? Maybe what we really need to do is to see the patients as individuals, not in terms of being a functional patient. And I believe that we get into this kind of a vicious cycle because of the stigmatization in this dualistic system, that the patient comes to the doctor, they have urgent visits, they request tests, we try to respond to that. The patient expects cure. The doctor will order lots of tests, will do referrals, will do, at times, increase the costs, and then this doesn't yield anything because you keep looking for structural disease, and then the patient gets frustrated. They start to wonder, is somebody missing something? So they go to another doctor. They get symptom-related anxiety and so on. So I think we're caught in this vicious cycle, and what is the solution? So I don't think the solution is to continue to search for disease. It's to abandon the idea of doing that. It's a don't just do something, stand there. I think what we have to do is accept their condition for what they have and then work with them toward management solutions. And this is a good point to make with patients. We've done enough studies. Let's start to look at ways we can help you get better. And we do that by understanding, listening, communicating. And that's what this is all about. We're going to try to talk about what are the communication things that we can do. Here's a study we did with Tony Lembo and Ted Kapchick, which shows the value of communication skills in the doctor-patient relationship. This was a study where there was a wait list, sham acupuncture, that was limited and augmented. And what we're looking at is improvement of IBS symptoms and improvement in quality of life. And it's clear that the augmented acupuncture was better than the sham acupuncture, the limited acupuncture, I'm sorry. What was the difference between the limited and the augmented? It was the same technique, but in the augmented acupuncture, the acupuncturist in the same amount of time was taught to be empathic and to listen and to be respectful and so on, whereas the limited acupuncturist just did the technique. So here's a good example of it's not what you do, but how you do it that makes a difference. So there are certain things that you can do, and I want to go through now the review of that. One of the things is you have to be careful about saying things that you think are valuable but are not, such as your problems are due to stress. Well, if the patient doesn't bring that up, that can be a negative kind of issue. Or, I'd like to order a few tests, I think they'll be negative. And then the question will question, why are you ordering those tests? These are things that we think are helpful, but they're not necessarily. There are some data to say what leads to improvement. One of the first things is, what are the things that bring patient satisfaction? I'm going to be summarizing a lot of studies now, but there are 4 important things. One is the patient has to feel the doctor is humane, has a sense of humaneness, however that's defined. They have to have an interest in psychosocial skills. They have to be perceived as technically competent, and they also have to provide medical information. This is work from Deborah Roeder and Wendy Hall. The provision of too much biomedical information is a negative factor. If you get too involved with giving them details and doing tests, that has a negative factor. There also are some things that are what we call engaging the patient, where the patient walks away and say, that person really believes me, and the engagement has been shown to improve outcome. And what are the things that's shown on here? Close interpersonal distance, a partner-like relationship, good eye contact, affirmative nods and gestures, and a gentle tone of voice. They're so simple, but these are what patients respond to from these studies. And then finally, for the doctor, what's really very interesting is that it's been shown that when doctors learn communication skills, they tend to like their patients more because they're getting feedback. Even in the role plays that you'll have tomorrow, you'll get to like your patient better if you have good communication with them. And then doctors, of course, feel better as well. And so you lead to improved outcome. So what I want to try to do is take you through what some of the guidelines are. You can use this for tomorrow when we start working with the patients. The first is listening actively. This is not cocktail discussions. I use the analogy, you're at a cocktail party, you're talking about your children, they're talking about their children, and you're not hearing anything the other person's saying, you're just waiting for them to stop to talk about your own children. So listening actively really is actively hearing what they're saying in order to gauge what your next response is going to be. So you're using their information, and that's where good interviewers do well. They're hearing what they're saying, and they're able to take it forward. Identifying the agenda. Patients come with agendas. Sometimes their agenda is very right up front. Sometimes it's what we call preconscious. It doesn't come up until the discussion gets going. And sometimes the agenda may not even be in their mind, but it could be affecting their behavior. And you have to then bring it up to them. And there are a few questions that I like to ask. What brought you here today? You know, it's the old story of the patient with back pain for 5 years who comes to the emergency room at 3 a.m. and then everybody complains about them coming in. What brought them here today? Another question I think is important is, what do you think you have? I think I've got an infection going on in my stomach that nobody's been able to find. Well, it might be that you've had this pain for 6 months and there's no infection, but you can use that information to frame how you're going to respond. Well, you may have had an infection at one time. You don't have an infection now, but it's as if you still have the infection because the nerves have been altered, like a phantom limb, for example. What worries or concerns do you have? What's the most common concern that patients have?
Cancer.
But they often don't say it. And it's interesting because sometimes the patient will come to you thinking, do I have cancer? They tell you about the symptoms. They don't ask about it. The doctor sees, oh, this is irritable bowel. They reassure them. They say, everything's fine. Don't worry about it. And the patient walks out. And what is the patient saying as they walk out? Do I have cancer? Because if you ask what worries or concerns you have, it'll come up. And once it comes up, you have something to work with and you can get a response. And then finally, what do you feel I can do to help? Again, common is, I want you to take away this pain and cure me. And they've had the pain for 20 years. If you don't get that on the table initially, they're going to walk away, and 3 months later they'll come back and say, I'm not any better. And you thought you had a totally different agenda with them, which is to manage their symptoms, but they were expecting cure. Empathize. Empathize, as you all know, is not experiencing their pain, but understanding their pain and having a more objective stance about it. This is an example of an empathic statement. I can see how difficult it has been to manage with your pain. It's creating a bridge to the patient. It's letting the patient has a different response. They're interpreting this doctor in a way that's different from, tell me more about the pain. They feel that you're somehow connected. And validation is very similar to empathy, but validation is telling the patient, I understand what you're experiencing. It doesn't mean you agree. Here's a good example of a validating experience that you don't necessarily agree with. I can see you're frustrated when people say this is due to stress, and you know it's real. Now, if the patient hears that and feels validated for it, you can go on to talk about the role of stress, that it might affect them as well. Well, let me show you a video.
Well, you've given me a pretty good idea about the nature of the pain. I guess I want to understand a little bit more about what makes it worse. Are you aware of anything like diet, activity, or stress?
You don't think this is in my head, do you?
I guess I need to understand better why you're asking me that.
Well, several physicians have suggested that stress is what's causing my pain. And Dr. Smith, my primary care doc, have sent me even to a psychiatrist. And the psychiatrist thought I'm fine. And I know I'm not crazy. It's not in my head, and I did not have this pain before, and this is very frustrating.
So I guess you're concerned that other doctors are saying that this is stress, and you're wondering by my question whether I think that this is a psychiatric problem?
How would you feel?
Well, you know, as a result of our evaluation today, I know that your GI symptoms are very real. And this is not a psychiatric condition, this is a GI condition. But just like any other condition, I think we need to understand what factors make it worse. And there can be things like physical activity or stress. And one of our jobs is going to be to try to see which kinds of things might make it worse. And then by having that information, we can work out some solutions.
So you don't think it's in my head?
No, I don't think it's a psychiatric problem at all.
Okay.
If you say yes, it's due to stress, the nature of the question will make them start to fold their arms once you tell them that. If you say no, it's not due to stress, you're not true to yourself or true to the education you need to do. So what I did is I asked for more data. Why are you asking that? The more you can get the patient to ask and provide more data, the more you can respond to that. And then I could say to them, so you're wondering by my question if I think it's a psychiatric problem. She provided the inroad for me to ask that. And when she said yes, I can distinguish the stigmatizing term psychiatric and then from stress later. So I could say it's not a psychiatric problem, but stress can affect all symptoms. So if I said that earlier on, she never would have heard it. What I was trying to do was to create a receptivity to be able to hear it. And then I validated the patient's feeling. Setting realistic goals. I used the example before about the infection. Or what are you coming here? I want you to cure me. And you may then have to try to address the fact that this is a chronic condition. The patient may not want to hear it. So here's an example of how that might happen.
I've taken 3 Darvocets before I came here. That's why I'm so comfortable now. The pain is really, really bad. Is there something you can do?
Well, I guess maybe we should, I would like to get a better sense of what your expectations were at this point about how you would be doing.
Well, I was just hoping I don't have to take Darvocets all the time, and that my pain will be better.
Yeah.
That's all.
What would be better?
Well, gone will be good.
Yeah.
I want it gone.
Yeah. And you've had this for how long now, this pain?
Years.
Yeah. Well, I'm just wondering that...
I'm tired.
Yeah. I'm just wondering that maybe we didn't really talk about expectations on the first visit, and you're coming to me now expecting that the symptoms would be gone, but I guess I've seen this as a very different kind of management. You know, you've had pain for many, many years, and I think we have to be realistic in terms of what our expectations are.
You mean I have to live with this?
Well, you do have a chronic condition, much like arthritis, and you know, the disorder doesn't go away, but it goes up and down in terms of its intensity and severity, and what we work on are ways to manage and keep the symptoms under better control.
You mean I'll have to live with this? It's starting again now. I have to live with this forever?
Well, it sounds like that after all these years of pain, your expectation was that it would go away completely, and I think that while we hope that would be the case, is not fully realistic. I think we have to look at ways to reduce the symptoms and make you feel more able to control them.
I cannot function with this pain. I have to get better. I cannot work. I cannot take care of my daughter. My marriage is falling apart. You've got to help me. I just cannot live with this.
Well, you know, you've raised many different types of concerns and issues that we may need to understand and address better. And I think with regard to the pain, realistically, it may not go away, but I'm just wondering if we were to get your symptoms down about 25 or 35%, if that would be beneficial to you.
Well, it would. I don't know whether I can work still, but I'll take it.
What are your observations here?
Tough patient. Tough patient.
Tough patient?
Just the way the officer, it's very realistic.
Wasn't it really annoying when she started to squirm around like that? Put a 1 in front of it. No. What did I do? What was I doing? First of all, this gets back to Lynn's statement. These are behaviors that are ingrained sometimes all their life. So what you have to do is to provide some sort of consistency and direction, and you have to accept the fact that they're not, you know, what do doctors want? They want patients they want to make a diagnosis, they want the patient to get better, and they want to be thanked for the effort. That may not happen with patients like this. So you have to think about different goals. And one of them is to develop a consistency in the way you're responding to it and providing a direction. So I said the right things. We'll talk about in a second what the right things were. But it may not happen immediately.
Definitely try to reframe expectations.
That's right, because there she was wanting the pain to go away, and you knew that wasn't going to happen. And she came back 3 months later saying, I'm not any better now. And I had to backtrack and say, maybe we didn't talk about goals and expectations. What were you expecting? And you said, I want to not have to take Darvocets. Yeah. Are you enrolled now?
As a physician, it's very easy for us to feel comfortable and responsible if a patient like this expresses dissatisfaction. Because we feel we're trying to cure, we're trying to fix. And what was remarkable in your response here, I think, is that you did not take any of this on you. You did not associate with anybody. You didn't take it personally in any way. You realize that this is part of where the patient is.
That's right. And I basically didn't get angry or defensive, which is a common response. When patients are angry or complaining, you tend to react to that. On the other hand, if the patient is sad, you tend to move forward with them. And that can be a trap too, because if a patient has lived a life of crying in front of everybody, that might be a behavior to bring on attention and not lead to real growth. So these are the subtle things. So if you want to look at what was done, I avoided responding defensively to the challenges. It's something you can do. You know, I could say, oh, of course we're going to work with you. I could do that, but I may be making promises that might put a wrong level of expectation. Of course, I could say, of course, we're going to work together on this, but this may take time, might be more realistic. I asked about patient expectations, and I said that mutual realistic goals were not established. And the important thing is, there she is squirming and moving forward. It's starting to come on now. And what am I doing? Nothing. It's there. I'm seeing it, but I'm not providing feedback to the behavior, because that behavior can be maladaptive. I want to move forward. You know, one of the, Dennis Turk did a study to show that the prescribing of narcotics, the strongest predictor of that is the patient's nonverbal behavior. Not that they say they're in pain, not their condition, not how long they've had the pain, it's when they squirm around. That's when the doctor prescribes it. And then I acknowledged the concerns without needing to do something. And then I gave a realistic goal. And in the end, she said, well, I'll give it a try. Education is not a brochure. It's an iterative process. You elicit the patient's understanding. You address the misunderstandings. You provide information that's based on what they've said, and you check the patient's understanding. Reassurance is not a pat on the back. You ask what their worries and concerns are, you acknowledge them, and you respond to the specific concerns, as opposed to false reassurance, everything's okay, you'll be fine. Sometimes doctors will do that before they've even done the physical exam. Now, the traditional doctor relationship was the doctor up here, the patient up here, and then it kind of shifted to patient-centered care. And I'm going to tell you, I don't think that's the right word. I think it's now become so picked up by ACOs and organizations, and they have no idea what they're talking about, because they're looking at patient-centered care as some way to find better ways to make money. The real term is relationship-centered care. Relationship-centered care is one where you come to negotiate an understanding about things. You respond to the questions, you provide suggestions, and then you work on a mutual goal. And the advantage of doing that is that when you have a mutual goal, if it doesn't work, it's not the patient's fault, because they're reassured that you're working with them, and you don't have to feel that you did something wrong by not getting them better. So with negotiated care, you have common goals, and then when they come back and they say, I'm not feeling any better, you could say, what do you think we should do now? See, you're given a different model of care. This last item is that sometimes patients will bring up things that they never intended to bring up. It could be emotional. You may not be prepared for it. In a role play yesterday, I came up with something that the patient wasn't prepared for. This can happen, and it can lead to all sorts of thoughts and feelings. And so I know I'm out of time, but I wanted to show the last of how you want to provide support and a listening ear.
You know, you've told me about your symptoms, and you brought up on several times about how you felt very helpless and out of control and vulnerable with these symptoms. Mm-hmm. I'm just wondering if there are other times in your life where you've had similar types of experiences.
Well, is that important?
Well, I was trying to understand the feelings that these symptoms have generated.
Well, my childhood wasn't, always pleasant. My father was an alcoholic. He wasn't very nice when he was drunk. But I don't see how this has anything to do with my pain.
Well, I guess you're bringing that up now. Were there certain feelings that were generated or experiences that brought on those feelings?
Yeah, I actually don't particularly like talking about it, but probably age 5 to age 15 when he left, when my mom left, it was pretty rough.
I see.
He was not a good man. I really don't want to talk about it now.
Yeah. Well, I guess I was just looking to understand if there was any relation between the symptoms and the feelings generated now and the feelings generated then. It sounds to me that there may have been some feelings that made you feel out of control and helpless then too, and maybe that's having a role in the symptoms now.
Oh, I was totally out of control.
Yeah.
I was scared. I was hiding when he would come home because I knew what was going to happen.
Yeah.
But he's gone now,
Yeah.
and I have this pain.
Right. Well, you know, what struck me is that in describing the pain, you use the very same words, and there's no question in my mind that those very difficult experiences can be almost indelible in your mind. And
You think?
well, they're issues that you have to work through, and I'm just wondering if you're having those feelings now with your symptoms, that in some ways it's kind of bringing you back to that feeling of helplessness and lack of control. And that's something we can work on now. We can't change the past, but we can maybe work on these symptoms now in a way that you're not responding as if you were a little girl.
Okay. I think I'm still a little girl.
Well, what we need to do is to have you work with these symptoms in a way that puts you right back in control. And I just have a feeling that in doing that, these symptoms will be much more manageable.
But is that possible? Can you turn the clock back?
Can I turn the clock back? Well, I think that's something we can decide. Obviously, this is something that you find very difficult to talk about. And if you are interested in addressing this further, perhaps we can talk about it, or might have you see one of my colleagues who can work with you on that.
I don't know.
Yeah.
I haven't talked about it to anybody.
So it's really been preying on your mind some?
It's been better. It did for a long time.
Yeah.
This is really hard. Anyway, what are we going to do now?
Well, I think now's the time where we can work together to get you feeling more in control of your symptoms and maybe find better ways to manage your symptoms. I'd also like to be available to you if you want to discuss those past experiences and see if we can make some decisions about what to do about that.
Thank you.
So what I did here was I used questions and reflections, no judgments. I addressed the feelings of helpless and out of control, which were related to the symptoms, and I reflected on the similarity of these to the feelings earlier. And most of the time I was using silence and reflection. I wasn't offering very much. And then I acknowledged options for further explanation. She wasn't looking to go for it right now, but I kept offering it. And then I just offered availability in the future. That's about the best you could have done in this situation. So, with that, I thank you for your attention. Okay.